Thanks for joining us. I'm Chris Wallis here at ASCO GU 2024. I'm really happy to be joined by Dr. Pedro Barata, giving us his thoughts on a few different data points we're seeing at today's meeting. And so maybe we'll start in the prostate cancer space. Treatment intensification, systemic therapy with an ADT backbone and something else has really become our standard of care.
Right.
But uptake hasn't been as good in the community as I think many of us would hope. And so, there's some data being presented at today's meeting about, maybe patient factors and other things that may contribute to real-world decision-making in treatment intensification. So I'm interested in your thoughts in terms of, what we're seeing and how that influences how you select patients for treatment intensification in the clinic.
Sure. Well, first of all, thank you for having me here, Chris. Fantastic work. And as you said, it's really an important topic, right? As we found out that actually, doing treatment intensification, which appears to be the term that we now use, that basically means castration plus something else. And that something else could mean a novel monotherapy, androgen signaling pathway signaling by itself, or that plus chemotherapy. So we normally refer to those as doublet or triple therapy, right? The adoption of these regimens, this is all based on phase 3 data, so showing a benefit in all endpoints you want to consider from the efficacy perspective. So you delay time to progression CRPC, you delay time to symptoms, you improve overall survival, and it seems like there's no deterioration of patients' quality of life. Mm-hmm. So there's really, the question, why hasn't this been adopted the way we thought it would be adopted by now, right, by the community overall? And I think there's a lot of reasons for that, right? Certainly, it takes time to pick up and to adopt novel practices. We have to think that a lot of us were practicing before in a world where we were sequencing one therapy followed by the other. It takes time to change those practices. It's also, relevant that I don't think we have 100% pool of patients, because remember, the patients that we see in the clinic are those who are good enough to come and see us. Mm-hmm. So, when we look at data from a broader perspective, we also including patients that unfortunately are very sick from their disease, admitted at the hospital, end up be good candidates for best supportive care. I'm not saying that's probably represents the minority of the patients. I don't know if it's 10, 20%, 15% maybe, but that means that the pool of patients that are suitable for treatment intensification, it's not 100% of patients that you and I commonly talk about. So I think those factors do matter. I think raising awareness of these, how the management of this disease in the metastatic hormone-sensitive disease change over time is relevant to bring up. Speaking of that, we just got to work then Dan Spratt and led, which basically look at the data out there from all these phase 3 trials, over 10 of those trials, and basically ask also the question about age. How do we, is anyone a good candidate for a treatment intensification? And we start having some questions around, tumor volume. Certainly we started there. Also, newly diagnosed disease versus recurrent disease, because we do know those are prognostic factors, especially patients with high volume disease and certainly those with newly diagnosed disease, but also the question around age. Mm-hmm. This was initially, I think, brought up in the PEACE-1 study that investigated triple therapy, with ADT, docetaxel, abiraterone, but it's really the question about, can anyone receive therapy in a safely manner? So then, in the group, I'm happy to be part of that, but basically they look at all the data available out there in a form of a meta-analysis and ask the question, does age matter? Is that, is impacting the results that we see? And apparently, with all the limitations on not having access to individual patient data, I think it looks like the benefit is still there, but it seems to be less strong or a weaker benefit, I guess, compared to a younger population. I think we got to be careful with those statements, because we certainly don't want to pass the message that, older individual, which by the way, it also depends the definition. Sometimes it's over 70, sometimes 65. So it depends on exactly the study you're looking at. But we certainly don't want to tell the folks out there in the community that if you have 70-year-old, you should not be offered treatment intensification. That is not the point. Mm-hmm. What we're looking at is obviously as you get older, you are at risk for other things that are not necessarily related to cancer, number one. Number two, you might be at the increased risk for some toxicity from therapies. With that said, I do consider the treatments available out there to be safe. I do take that as a factor I do factor that in, but it's certainly not my only factor when I decide what type of treatment intensification am I going to offer the patient in front of me. Am I going to do androgen signaling pathway with hormones, or am I going to do that in combination, in addition to chemotherapy with docetaxel? And I think there's a number of factors, but I just want to mention that as one of the work that we presented here at ASCO GU.
Absolutely, and I think it sounds like what I'm hearing is, it's less about the treatment choice and maybe more about the patient counseling and setting expectations and understanding that maybe there's a little less bang for your buck, but it's probably still worthwhile. These older patients still, as long as they can tolerate it, benefit and warrant this intensification. And and a similar idea of trying to find the best treatments for individual patients, you've also got some data here at this meeting looking at biomarkers and SPOP status as a marker for treatment response in patients with prostate cancer. There's sort of a little bit of insight. I know this is already filtered into the guidelines.
Right, exactly. I mean, you raise a very important point. I think it came pioneered work from Dr. Niraj and others from Huntsman and other groups, and basically, highlighted the role of SPOP mutations in predicting response to hormonal therapy and castration. Right, it's a very important point, including the guidelines as you alluded to. So we do expect those patients to do better on hormonal therapy, and apparently we did that in a real-world consortium, a group called PROMISE. Brenna McKay is the lead author for that wonderful work, and basically you can see there that actually the outcomes of those patients were better compared with those without SPOP mutations. So it's relevant because we're getting in the world of personalization of treatments. We're really getting the information beyond clinical and demographics, getting information about the tumor and the molecular characterization of those tumors does help us how we make decisions and how we should also inform the patient about what to expect in terms of efficacy of those regimens, but also in terms of outcomes. So I think SPOP is a very informative and important story that I think is very relevant for us to know in the community, because it helps us to make decisions. So those patients are less likely, for example, to be offered, a triple therapy, for example, compared to a doublet, and the outcomes seem to be going that direction.
Right. And so, do you think we're at the stage where this is ready for routine testing? Should everyone be getting SPOP mutation status as part of their diagnostic evaluation with the HRR mutation and that sort of a panel? Right.
So in my practice, I do. In my practice, I get all transcriptome and all exome sequencing data. So initially all these patients get castration, and so I don't do everything at the same time, the same visit, because it can be overwhelming to patients, right? You're going to explain the amount of disease, what does newly diagnosed metastatic castration-sensitive prostate cancer really means. It's a long word, right? A long number of words and long sentence, and you want to explain what treatments do, what is going to happen. You also need to talk about genomics. You also need to talk about what expectations are, etc. You need to talk about bone health, exercise, diet, castration-related side effects, etc. It's huge, right? So I found that, at least in my practice, that breaking it down in a number of visits is very helpful. So what you can do is actually you can initiate the conversation around castration, explain the concept of treatment intensification, and also explain that we knowing more about the tumor and about the patient, tumor somatic genetic testing, patient germline testing, we can use potentially that information to treat patients. And then when you have that information about the right staging, patients are already castrated, and you will offer treatment intensification, which is the standard of care, then I think having information like SPOP, or instead homologous recombination deficiency or aggressive variant with CTP53, RB1, PTEN, right, in addition to tumor volume, right? I think all of that put together, I think we are closer to make the better decision what type of treatment intensification that particular patient can get. And I don't want to forget also potential interactions with medications, because patients don't come to us without taking anything else. They can take anticoagulations, high blood pressure medicines, etc., anti-diabetic, and some of these therapies can have potential interactions with some of the, of the therapies we use. So all of that, I do believe it needs to be taken in consideration today, but I do think over time we're going to get better at selecting, what type of treatment intensification patients should get.